is Czoli. I'm pleased to be your host for this evening. I'm trained as a public health researcher, having completed my PhD at the University of Waterloo. I'm also a supporter of the Ukrainian-Canadian Congress, and for that reason, I'm very pleased to be your host for this evening. Tonight, we have a very timely, a very informative program organized for you all on the topic of COVID-19 vaccines. Tonight's event is presented by the National Ukrainian-Canadian Congress and 19toZero, a national coalition of public health experts. Since March of 2020, the Ukrainian-Canadian Congress has been working to support our community with resources, with information, and with programming as we face the COVID-19 pandemic. Tonight's event is about helping to answer your questions about COVID-19 vaccines. If you have questions, I invite you to submit them using the question and answer function through Zoom. We'll be doing our best to track questions throughout the evening and pose them to our speakers. We're going to run for about 60 minutes this evening, and we'll try to cover as much content and questions as we can. So in terms of our program, we're going to have a short presentation from our friends at 19toZero. But before that, I'd like to just introduce our panelists who you see here. These are all well-known Ukrainian-Canadian physicians in our community. First, we have Dr. Olesia Markevych joining us from Edmonton. She is trained as a family medicine and sport and exercise medicine physician. Her current roles include working as a sport medicine specialist, varsity athlete physician, surgical assistant, and clinical lecturer for the Department of Family Medicine at the University of Alberta. Dr. Yuri Huculak, joining us from Toronto, has worked in family practice and community practice for the past 30 years. He has done some long-term care home practice during this time as well, and we're happy for him to join us this evening. Dr. Artem Luhovy, joining us from Montreal, is a family physician who also works at a COVID evaluation center in Montreal North since the beginning of the pandemic. So a warm welcome to our panel of community physicians. Thank you for taking the time out of your busy schedules to join us this evening. Tonight's main presentation will be by Dr. Cora Constantinescu of 19toZero. You also see up on our screen. Dr. Cora Constantinescu practices pediatric infectious disease in Calgary, Alberta. From seeing vaccine-hesitant patients in clinic to her academic pursuits in vaccine acceptance and surveillance, she has a strong passion for vaccine research and promotion. She holds a medical educator appointment with the University of Calgary, specializing in developing curricula and education programs rooted in psychosocial determinants of behavior change. She co-leads the 19toZero healthcare worker education team and continues to be a vaccine advocate at the local and national levels. Dr. Constantinescu also has a weekly CBC television Newsnet segment addressing COVID-19 vaccine questions and supporting Canadians as they make the vaccination decision. So certainly playing a critical role at this time. We're very happy to have Dr. Constantinescu lead us into her presentation. So I'll hand it over to her to begin with that.
Thank you for that fantastic introduction. And I'm going to go ahead and share my screen. Give me 1 second here. This is always the most complicated part of the whole presentation, is getting the technology just right. And I think you're seeing it now. So thank you very much for having me. It's a real treat to be invited. This is something I feel quite passionate about, and I'm happy to talk to you a little bit. We're going to do a bit of a primer on the COVID-19 vaccines, and then we'll take questions and answers at the end. I am presenting to you from beautiful and sunny Calgary today. Who knows what tomorrow or the next week will bring. But I do want to acknowledge that Calgary is on the traditional territories of the people of the Treaty 7 region, and that includes the Blackfoot Confederacy, and comprising of Siksika, Piikani, and the Kainai First Nations, as well as the Tsuut'ina First Nation, the Stoney Nakoda Nation, and the city of Calgary is also home to the Métis Nation of Alberta Region 3. We're going to talk a little bit about the different COVID-19, the ones that the vaccines that we have authorized in our country currently and are offering, and then also address some of your questions and concerns about it, some of them already in the presentation and some afterwards. This is my all-time favorite slide because it shows that we have over 8 million doses of COVID-19 vaccine administered to Canadians. In Alberta, we have over 900,000. In Ontario, we have over 3 million. We're now at about just under 20% of our population having had one dose of the COVID-19 vaccine. And this is all, when you think about it, around the world, there's been over 800 million doses of vaccines administered. And what I love about this slide is that it's already out of date. Even though I've updated this as of yesterday, we know that we already have more vaccines having been administered to our population already. Now, I want to talk to you a little bit about the regulatory approval. We have 4 authorized vaccines in Canada against COVID-19, making this our top vaccine preventable disease right now. But a lot of people were concerned because this is a record timing in terms of development. So this vaccine was the first COVID-19 vaccine actually was on the tarmac, arrived in Canada in December, less than a year before the pandemic was declared. So a lot of people had concerns about how fast this was done. Prior to this, 4 years had been the other previous record to vaccine development. The biggest reason why this happened was because they already used platforms that were already in place. So a lot of these mRNA platforms, the viral vector vaccine platforms we'll talk about, were already developed at the time where they actually, when the actual virus was sequenced, which was very quickly. And it was a bit like a CD player. I've heard this analogy and I really like it. It's like a CD player. You already have the CD player and you're just changing the CD that goes into this platform. What I want to outline to you is there were a few things that were done very well, specifically safety. Because these studies were huge, they were anywhere between 20 to 40,000 people in the phase 3 trials. Typically, prior to this, to get a vaccine to market, you had to be between 6 to 8,000 people in a clinical trial. So we're talking way larger than before. So because of that, safety was not compromised in terms of phase 3. But efficacy, which means how well the vaccine reached whatever endpoint the trial had, most commonly it would be symptomatic COVID disease, was a little bit because we did not know at that time the duration of protection. So we wouldn't know. We knew that people were protected within a month, 2, 3 months, but we didn't have vaccine protection knowledge. Now we know that with the mRNA vaccines, it seems protection lasts at least 6 months and most likely longer. The one other thing we lost in those trials were the populations. So again, there were some populations that just could not be included, and that would be breastfeeding and pregnant women, children, immunocompromised people. So this is exactly where you're going to see more information come out and more studies as now the vaccines have been administered to millions of people around the world. Then we can look back and say, okay, well, what happens when these vaccines are given in these populations? And as a case in point, I'll share with you some information on pregnancy from the vaccines in just a few slides. We have 2 main vaccines, the mRNA and the viral vector vaccines. 2 types of vaccines, 2 mRNA vaccines and 2 viral vector vaccines authorized in Canada. Novavax, which is a different platform, has been submitted to Health Canada, but as yet we do not have, that's not authorized yet in our country. All of these vaccines contain some form of genetic material, whether it's either an mRNA or a DNA of the spike protein. The spike protein is a protein on the actual virus that our immune system recognizes and builds immunity to it. The mRNA vaccines, the mRNA is like a recipe. So you have this recipe on how to make the spike protein inside a nanoparticle that's being injected. Then our own ribosomes make that mRNA into protein, into spike protein. Our immune system sees the spike protein and builds antibodies to it. The spike protein as well as the mRNA get degraded by the body pretty quickly after being produced. In the viral vector vaccine, the viral vector is kind of like a delivery truck. It's an adenovirus, which is a special virus that has been made not to be able to replicate inside the body. Typically, when you have a virus inside the body, the virus takes over the machinery, makes lots of copies of itself. But in this case, the virus makes copies of the virus makes your cells make copies of just the spike protein. Again, the spike protein is then recognized by the immune system. Antibodies are built to it. The viral vector, the adenovirus, as well as the spike proteins are gotten rid of by the body. In terms of efficacy, I tell you there were a few things where I teared up in this whole pandemic process. And when these mRNA vaccines announcements were made, they were 95% protective. It was a really emotional time because what we know is that as we age, our immune system ages with us. It's something called immune senescence. So we don't always see people who are older have good reactions and responses to vaccines. They tend to not work as well in the older population, but these vaccines maintain this kind of efficacy in people who are older as well. And we know that those were the most vulnerable. So 95% for the Pfizer BioNTech mRNA vaccine, 94% for the Moderna vaccine. And again, they had between 30 to 40,000 people included in their studies. In the viral vector vaccines, we have two. One is called the AstraZeneca vaccine and the Johnson & Johnson vaccine. The AstraZeneca vaccine had a bit of a bumpy road for sure. There were multiple studies that were done in the phase 3 versus one big study. The data was a bit messier. They had different dosages, different intervals when they were giving the dosages. The initial study showed the vaccine was about 68 or so percent, somewhere between 60 to 68% effective. But then they had a larger study done in the US. They showed 76% protection against disease and 100% protection from severe disease. In the Johnson & Johnson, the big claim to fame of Johnson & Johnson is that this is only a one-dose vaccine. This showed to be 66% protective against disease and 85% against severe disease. And in the trial, they had 0 deaths as well in the vaccinated patients. What I want to bring to your attention, and you'll hear me talk about this again, is that both of these vaccines are really good at preventing severe disease, hospitalization, and therefore death. And the reason our whole country and the world has come to a standstill is because of the issues around hospitalizations, ICU stay, and death. So if we can prevent that, then that plays a huge role to the effect this pandemic has on our society. And again, shown to work in different ethnicities and ages, which I tell you was this incredible relief for me, having studied vaccinology before because of this phenomenon of immune senescence, so aging of the immune system. We don't always see good responses in older people. So reassuring to see that these vaccines had done well in the people who needed it the very most to begin with. So the big differences in them, I'm sorry, I just got trigger happy there. I went through 2 slides. And so both of them are, so the mRNA vaccines are, mRNA gives you the instructions about the spike protein, 2 doses, highly effective, and again, very good at preventing severe disease and hospitalization. Now we have a bit more real world data from mRNA vaccines, and I'll show you some of that. And we're starting to see some real world data from the AstraZeneca and the viral vector vaccines as well. AstraZeneca has 2 doses, Johnson & Johnson 1 dose. Again, very effective at preventing severe disease and hospitalization. The big advantages of the viral vector vaccines is can be stored in regular fridges for up to 6 months. Compare that to the Pfizer BioNTech vaccine that can be stored in a regular fridge for about 5 days. And minus 80, not even Edmonton and Calgary can be the right place for these vaccines. You need specialized freezers to maintain these kind of vaccines, so not as easily accessible to, especially to parts that of the world and of Canada that may not have the ability to have such freezers. Big question has always been about vaccine side effects. If you're going to ask anybody, the first thing they want to know is whether or not the vaccine is safe. We expect vaccine reactions from non-live vaccines, so all of these 4 vaccines are not live, to occur within 6 weeks of vaccination. A lot of people worry about long-term effects of vaccines, which I think is a normal reaction to think about long-term effects and worry about them. But these are non-live vaccines, and we shouldn't expect to see anything past the initial first few weeks. And we certainly haven't seen anything long-term so far. And remember, some of these vaccines were started in in July of last year. We don't see long term. Anytime anybody has looked at long term effects from vaccines in the past, in terms of childhood vaccines and other vaccines, we've never seen any long term effects. I do want to bring your attention, however, to the fact that with COVID disease, there are long term effects and sequelae, and there are some data, which again is totally fascinating, that if you have somebody who's had COVID in the past, who has some of these long, like they're long haulers or they have long COVID, those symptoms seem to go away once they get vaccinated. So if anything, it might help long-term effects from COVID disease. You cannot get the disease from the vaccine because you're just getting a piece of that. You're just getting all you're getting is the recipe for their spike protein of the virus, not the rest of the virus. Sorry, I thought one of my children was going to invade me at any point, which might still happen through the presentation. So here is how I like to talk about these reactions from vaccines. 8 in 10 people, so these are reactogenic vaccines, especially the mRNA vaccines. 8 in 10 people complain of a sore arm, but only 1 in 100 call that soreness severe. 5 in 10 people complain of feeling tired and having a headache, but only 1 in 10 need to take Advil or Tylenol for that. We expect some reactions. They tend to be more reactogenic. However, most of these reactions are going to be managed at home and tend to be reasonably mild. Here's the part where it gets really exciting and interesting. So this is where it happens when the vaccines are being given to millions of people out in the real world. What I spoke about until now is what we call efficacy, which is how good the vaccines are at reaching an endpoint such as preventing symptomatic disease in a very perfect, ideal clinical trial condition. But what happens when the vaccine is out in the real world is called effectiveness. And what's really, really promising and so amazing is that these vaccines are showing to maintain that efficacy. It translates into effectiveness in the real world. So this is data out of Israel, where they had immunized almost half of their population. So at this point, they had over 1.2 million people who they looked at. Half of them had had the vaccine. And 7 days after the second dose, they had reduced asymptomatic infection. So this is those spreaders people talk about. So can you spread the disease if you don't have symptoms? They had reduced asymptomatic infection by 90%. They showed reduction in symptomatic illness by 96%, hospitalization by 96%, and severe critical illness and death by 96 and 93%. So we see that fantastic, amazing efficacy shown in the initial trials translates into the effectiveness in the real world. This is 7 days after the second dose. Again, if you're going to ask, a common question for us in Canada is, well, what happens after one dose? Because we know that we've spaced the vaccine dosage out. After one dose, you're going to start seeing some response 12 to 14 days after. So the first 2 weeks after the one dose, you're not really protected. So that's really important to keep in mind. You need about 2 weeks after the first dose to get some response. And we're seeing about 80% in a healthy average individual, 80% protection against disease after one dose. But again, 2 weeks later. Um, there are there are more and more data coming out. So there are data from the UK and Scotland that show that even with one dose of the AstraZeneca vaccine, you can reduce hospitalization and severe disease by 94% after one dose. Now, here's the data from Canada. This is where it gets really exciting. So this is early data from BC, from the BC CDC. So on the x-axis, you have the days after the first dose of vaccination. On the y-axis, you have the number of cases after vaccination. And this is in people in long-term care residents, 65 and older. And they had shown protection more than 80%. And these are numbers. So these are people who didn't get COVID, who didn't end up hospitalized, who didn't end up dying of it. But you'll see there is that really 12 to 14 day is when you see the drop off. So in the first 2 weeks, you still see numbers of COVID anywhere between, the 0 to 20 on a daily basis. And then after 2 weeks, you see a nice drop off in our own population. And these are, again, the most vulnerable people, those over 65. They did the same thing looking at healthcare workers after vaccination. And again, this is one dose. This is first dose of the vaccine. This is not two doses. And again, after 12 to 14 days, you're seeing that drop in daily cases of COVID-19 after one dose of vaccination. And all of these are mRNA vaccines because this is what we were giving at that time. A quick slide on variants of concern. This is what keeps me up at night, especially as in Canada, we're struggling with 3 variants of concern. The B117, which I think will soon be the main variant in places like Alberta. We're now seeing over 50% of this, definitely large numbers in Ontario as well. The B1351, first described in South Africa, and the P1 variant first described in Brazil. Where we're at with how good the vaccines are, they seem to maintain their efficacy against the B117, and there is some indication that they might maintain efficacy against P1, maybe not as high as they initially as those as the wilds or the ancestral strain, but some maintenance. There is concern, however, with a lot of these vaccines having reduced effectiveness against B1351. So stay tuned. We'll know more and more as more of these vaccines are being given in the world and as unfortunately more variants are taking over. If we can stop the spread of this virus from person to person and we stop its replication, then we're going to stop the variants that come up. If we don't and we let it rip the way some parts of the world have done, then we're going to see mutations. Mutations lead to variants. So often the variants come out of the areas of highest transmission, which is why there is such a push for us not to be behind the variants, always trying to play catch up, but get ahead of them, which is why you're seeing a lot of these restrictions coming into the third wave, not just relying on vaccination to get our way out of the third wave. We have to get the numbers down to prevent the transmission and to prevent the viral replication, which in the end leads to mutations. A few slides on special circumstances. So this is what it's contraindicated on in people who have a severe allergy or anaphylaxis to the vaccine or an ingredient of the vaccine, people who've had another vaccine in the last 14 days. And typically after a COVID-19 vaccine, we want people to wait 28 days before getting another vaccine, so such as Shingrix or the pneumococcal vaccine. The reason for that is that we haven't studied the COVID-19 vaccine in conjunction at the same time in co-administration with other vaccines. These trials will come, but they have not yet been done. So we just want to give enough time to the immune system to kind of respond to both. Also, if you have active COVID disease, we ask people not to show up at the immunization center because they can infect other people. So that's a relative contraindication. A few slides on COVID-19 and thromboembolic events. You've heard a lot about this in the media, and I want to talk a little bit about it. You've heard probably that today Johnson & Johnson rollout was stopped, was temporarily stopped in the US. So this is what this is about. It's something called VIPIT, which is a vaccine-induced prothrombotic immune thrombocytopenia. It's a mouthful. But what it ends up being is that they believe the mechanism is that somehow the platelets get activated. Platelets are clotting cells in the body, and then they get used up while clotting various vessels. The most significant vessels being in the brain, in the abdomen as well. The VIPIT comes with high fatality. So overall, they've had about 40% people die with it. We think that's going to be significantly decreased if we have early recognition of this. There've been about 200 cases in the Astrazeneca vaccine in 30 million. So about 1 in 250,000. I also want to bring your attention to COVID disease. So this is the actual, if you were to get the actual disease, we know that the incidence of clots is incredibly high. This is a prothrombotic kind of disease. Up to 16 in 100 people can end up with a clot after they've had COVID. If you end up in ICU, you have a two in three people have a chance of are going to get a clot in ICU with COVID disease. So what are we doing right now about AstraZeneca and VIPIT? We recommend it in the age groups that are most likely to benefit. My apologies about this. Most likely to benefit from the vaccine and who have the lowest risk of adverse events. So this is why we're recommending it in people over 55, because we've seen most of it seems to happen within 20 days of the vaccine, mostly in people under 55. There might be a predisposition for women, but it's hard to tell at this point because most of the people who got AstraZeneca were younger healthcare worker, and most of them tend to be female. So it's hard to tell whether indeed it is because it is in women or whether because those are the ones that got immunized initially. It's important to recognize early signs of VIPIT, which present with persistent and severe headaches, especially after day 4, seizures, blurred vision, shortness of breath, chest pain, redness, specifically a rash around the injection site. The reason, however, we recommend this vaccine is because this vaccine has been shown time and time again to be very effective at preventing hospitalization, severe disease, and death. And saving lives is crucial in this really horrid variant driven third wave, which has brought more younger people to ICUs than we had ever seen in the COVID-19 pandemic. Canada right now has more new cases of COVID than any other place in the world. So we need to bring these numbers down. And we know that this vaccine saves lives because it prevents hospitalizations and it prevents severe disease from COVID. I also want to quickly tell you about pregnant women because this is kind of interesting. So, when initially this was presented, we said to people, well, go ahead, even if you're pregnant, go ahead and have the vaccine because the risk of COVID in pregnancy was so high in terms of severity and death, and also because the baby under 12 months of age is at high risk of COVID and they cannot get a vaccine. We now know that out of the US, they've had over 70,000 pregnancies in vaccinated women, and of those 4,000 are completed pregnancies. So the babies that were delivered with no increased risk of adverse events like stillbirths, miscarriages, or premature labor. So it seems to indeed show there is advantage to have this in pregnancy, and so far there haven't been any safety concerns, even in the 70,000 pregnant women that have had the vaccine. I'm a pediatrician and I'm very excited that we're soon going to be able to offer this to children. We suspect that before the start of the new school year, we'll be offering it to teenagers. Last slide here is how to discuss this vaccine. And the reason I have this slide is because you don't need to be a vaccinologist and you don't need to be an expert in this to still be able to share with your family and your friends and your colleagues why this vaccine is important to be taken and and to be a vaccine champion, so that ultimately we protect our entire community, and then our entire country, and ultimately the entire world, because we cannot be safe from COVID until everybody gets vaccinated. Because if we allow it in other parts of the world to grow and to spread, then we're always going to be fighting variants. So here's how I recommend that you consider discussion about this vaccine. It's really important to build common ground first. So connect before you can communicate. If people can relate to you and they can have some common ground with you, they're going to then listen to what you're saying to them. Always personalize the information. I like the saying, facts, people don't reject facts because they're untrue. They reject them because they don't apply to them. So if you can always put this in the context of their own disease and what this COVID pandemic has meant to their lives and to and to themselves personally, then it's going to resonate with people when you talk to them. And always share your own experience and opinions on the vaccine, because people cannot argue with your own experience, with your own opinion, and that is something you know. So connect before you communicate. Always talk about the conversation within the context of that person's life, and feel free to share your own take on the vaccine, and hopefully everyone can share their own experience on the vaccine too. Thank you very much. I will stop sharing and we'll open it up to questions.
Thank you so much, Dr. Constantinescu, for such an excellent overview. Very informative, and you covered a number of key topics. We're going to embark on our question and answer period now. So a quick reminder for any of our participants tuning in, if you have questions, please do submit them using the question and answer feature in Zoom. And to start us off, I'm going to actually turn to our panelists. We'd like to hear a little bit from our community physicians and their perspective in this pandemic. I'd like to ask each of you to talk a little bit about your practice and share some of the most frequent questions that you're hearing or that are being posed to you about COVID vaccines. I'll invite you to speak for a few minutes each, and why don't we start with Dr. Olesia Markevych.
Hi, okay. I'm just going to apologize in advance in case you hear my daughter pipe in because she is playing right here next to me. So I will try to keep this quick. So I think the most common question that I hear that people have, or the most common concern that I hear people have around the vaccine, has to do with its safety. And I think that was very well covered in the presentation in terms of the research that was done for the vaccine. And I think that the key here is that the research was not rushed in terms of the information that we have about how well the vaccine works and how safe it is something that we can be very confident in. And a lot of the steps that may have been sped up involved red tape, where a lot of the administrative things that go into that were accelerated because everyone saw the need. And so we got a vaccine faster because all the researchers and policymakers and people involved work together. And so I think that is something that I just wanted to highlight. And then maybe coming from a personal standpoint, my daughter was born in the middle of the pandemic. And if I had had the opportunity to have been vaccinated, I definitely would have been, and I have now, and while I'm still breastfeeding, and I do feel that was a decision I could have made confidently in terms of the safety for both myself and my daughter. So I just wanted to share that little story too.
Thank you so much. It really helps contextualize some of these experiences in the real world. So thank you for sharing. Why don't we move to Toronto now? Dr. Yuri Huculak, would you like to share a bit about your practice and common questions you're facing?
Sure, thank you. And thank you for doing this event. I think it's really important that we reach out to the community on a general level and communicate what's really going on. There's so many sources of information out there right now, and many of them are legitimate, but there are many that are out there also that are confusing people and spreading misinformation. And one thing I'm hearing an awful lot about is vaccine hesitancy as well. And sort of two types of hesitancy. One is they're just fearful of the vaccine because of the speed with which it was developed and approved. And I think that's been really well, addressed by Doctors Cora and Olesia. There's also the patient or the person who says, well, yeah, I think I'd get the vaccine, but I just want to wait and see. Some people get it first. I want to wait, let a bit of time pass, make sure it's okay and that people aren't dying off or suffering with it. And, I would say to those people, that's happened. The Israeli study that was referenced earlier, again, it was just under 600,000 people that were vaccinated compared to 600,000 people that were not vaccinated. And they saw huge improvements in rates of severe disease, hospitalization, and death. And those are sort of the endpoints that we're most concerned with. So to those people who are kind of on the fence or hesitating, I would say, if you are fortunate enough to get in and get your vaccine done, do it. I have contacts in England and in California where vaccination rates are much higher than in Canada, and they are slowly but surely returning to normal life. And I think with this third wave, there's talk that, there's fear still, there's frustration, but there's also anger. People are really frustrated with the length of time that this pandemic has been dragging on for. And, we can each empower ourselves and do what's right here, get vaccinated. And like I said, if you have a chance to do it, right on. Thank you.
Thank you so much. Why don't we move to Dr. Luhovy now from Montreal?
Sure. So, before I begin, basically, I work at a COVID evaluation center. So what does that mean? That means that people who have symptoms that may be COVID or somebody who has COVID is seen at our clinic. And one of the reasons that we were chosen as that site is because we're normally just an urgent care center with 30 GPs, 6 nurse practitioners, and we inadvertently became part of the epicenter of COVID at the time a year ago in Montreal North, because there are many multi-generational homes, lots of nurses live in the neighborhood, other people might work at a grocery store. So essentially it's a neighborhood full of essential workers in multi-generational homes. And they were sort of the canary in the coal mines because everyone who could have gotten exposed started showing symptoms, and then 2/3 of our staff ended up with COVID. And so we're really, happy that the vaccine is out because it is scary when your entire team gets isolated one after the other, with COVID, and you don't know what's going to happen to them and their families. And there's sort of no way to fight back besides trying to keep your distance, but you still have to evaluate patients. We obviously know a lot more than we did a year ago, but what's changed now is these variants. So, it's one thing to try and maintain these barriers and masks and things, but it's not going to work long term. We want to get back to normal, and the only thing that's been shown to permit some sort of normalcy, quickly is the vaccine. A common question I've been getting is, does it cause a false positive? So if I get the vaccine and now I do the PCR test to see if I have COVID, will it just say I have COVID because I had the vaccine? And to answer that, I think it answers some of the questions that we see in the panel is no, because it's an mRNA vaccine. So the mRNA is broken down fairly rapidly after exposure, and that's very different than the full sequence of the actual virus, which is being actively replicated. And so there's lots of time to pick it up. And then even the fragments of the actual virus can be detected by the PCR test, sometimes months later. And so, no, you can't get a false, positive from the vaccine. And this also explains sort of why, there's certain differences in the milliliters and things. it's sort of not that relevant, because the way the vaccine works is it's going to get replicated into a structure, and then your body will respond to that structure rather than the mRNA. So different people sort of tested different amounts to see what will end up working. You know, I think any company that can use slightly less eventually to increase production will probably do that eventually if they're allowed to. But that's sort of just at the time of trial, that was what happened. So the same, you know, conditions are then used once it's you know, available for distribution. But the quantity, it's like with a medication, it's often arbitrary. Some medications are 5 milligrams, others are 10. It doesn't really matter.
Thank you so much. I think that addresses some common concerns that, that have been raised. I think what we'll do now is to open it up for a few more questions and answers that have been posed. And I'll start with a question about side effects. So some people have heard that both in Canada and the US, people who have been vaccinated have said there was little to no reaction after the first dose, whereas after the second dose, there were more quote unquote side effects. Dr. Constantinescu, can I ask you to start us off in answering that one?
Yeah, so that's exactly correct. And the reason for that is that the first dose does something called priming your immune system. So it just kind of like says to your immune system, here is the spike protein, do something to it. And the immune system then gets a bit excited and builds some antibodies. But then the second dose is the one that boosts all that. So you're going to get whatever you had then plus an actual amplification of your immune response. That is very typical of a lot of vaccines. So when we look back on, let's say, the diphtheria tetanus vaccine, uncommon to see a reaction in the first one, but much more common to get reactions on subsequent doses, because by then the immune system has been like, aha, I've seen this before, I know what to do with it. So sure, you're going to get that sore arm and you're going to get symptoms of an immune response, which can be a headache, body aches, some people can get a fever. That's where that comes from. It's your own immune response to it. I'll tell you, I kind of get excited when people get a good response, because you always think like, okay, good, the immune system saw that. It doesn't mean, however, that if you don't get any reaction, it doesn't mean that you don't have a response. But usually it is it mirrors the fact that your immune system is working hard to protect you and to make antibodies against it.
Thank you. I'm going to pick up on that second dose. A few more questions that we've got coming in are really targeted to that step in the vaccination process. So I want to ask you, how important is it to get the second dose of the vaccine? And relatedly, what could happen if you miss that second dose?
Yeah, so I'll tell you about the second dose situation and why Canada is doing one dose. If we had enough vaccine, we would be doing 2 doses. The decision was made around a few things. So one is the fact that there was not enough vaccine to immunize everybody. And then imagine you have your parents and you have 1 dose of the vaccine, and you could give, sorry, you have 2 parents and you have 2 doses of the vaccine. You could give both doses to 1 parent and have that parent be 95% protected, or you could give each parent 1 dose and have them be about 80% protected. So that was the ethical decision that had to be made in terms of vaccine equity and just not enough vaccine for everybody. So that was the first part in the decision. The second part of the decision was that we had data from the Astrazeneca trial that if you gave the second dose of Astrazeneca right bang 4 weeks later, it wasn't as good as giving it later. So if you actually stretch that interval, you got better response. Potentially that could be related to the fact that your immune system has had a bit of time to kind of recognize what this is, and when it gets the second dose, it boosts it. The third part of why they made that decision had to do with having some evidence already that the vaccine had we had at least 2 months of immunity after the first dose, and some models were showing up to 6 months of immunity after the first dose. So they said, well, there's enough immunity here that protects about 80% or so after the first dose in people, and then they chose that 4-month because it wasn't as long as 6 months and not as short as 2 months. And hopefully we'll have enough vaccine soon enough to shorten that 4-month period to actually get people the second dose sooner. There are, however, certain groups that I think will need that second dose even at this stage. So there are now some studies that have shown that people who are immunocompromised, it's not a safety concern for them. So immunocompromised people can still get the vaccine. It's not a live vaccine, but they don't have as good of a response to it. So if you have a solid organ transplant, a solid cancer, and particularly if you have a blood cancer like leukemia or lymphoma, your response to the vaccine is most likely going to be significantly reduced. So the blood cancer people, 10-15% response compared to the average person. So very different. So those people, but once you provide the second dose, that bumped up. So I suspect that as soon as we have more vaccine, you've probably heard about this, that older people over 85, these people who are immunocompromised probably should get that second dose sooner. And I imagine we're going to change that. And that's how we're going to start giving people the second dose based on these kind of factors. Okay, that was a super long answer, but it's a complicated question and a fair question, and it causes a lot of frustration to a lot of people who, especially those ones who got one dose and were kind of expecting to get a second.
Absolutely. I like that you touched upon a couple of special populations. We have been getting questions about some of those. You mentioned people with blood cancers. Can you talk a little bit about any data on the effect of vaccination on kidney transplant recipients?
Yeah, so those people also had reduced responses, somewhere in the 30 to 40% if you had a solid organ transplant. So again, after one dose. So it did bump up to over 70% after the second dose. But overall, as we kind of predicted, because if you look at people who have had, whose immune systems are not intact, they're not going to have as good of a response, even with other vaccines. And it seems that with these vaccines as well, there's a reduced immunogenicity or protection. Now it gets a bit complicated because we cannot do studies where we have people who are so vulnerable and expose them to COVID and give them a placebo. That's not quite doable. So it gets complicated because when they looked at protection, they looked at their antibody response. Could it be that they were protected more even if they didn't have antibodies? It's conceivable, but they had to find what we kind of a correlate to the protection was looking at the antibody response. But for sure, all those people had significantly reduced antibody responses, the worst being the blood cancer patients.
Thank you. I want to change gears a little bit to talk about moving forward. We have a question about getting vaccinated in the future. Would this continue to need to be done? Would it be similar to what we see with the annual flu vaccines? So I'm going to ask Dr. Constantinescu to field that one. And maybe in that vein, I'll turn then to the panelists, give you a chance to collect your thoughts about whether you're also seeing any patients with the long COVID symptoms. Are you seeing people just coming in, or someone kind of further down the road? So Dr. Constantinescu, why don't we start with you?
Yeah, so here's the thing. If you had asked me this question 3-4 months ago, I would have said for sure we'll need some kind of a boost every so often. But I'm now a bit more optimistic about longevity of protection of these vaccines. I think we're probably going to get protection longer than we thought, longer than a year. They're definitely more efficacious and effective than any of the flu vaccines we've ever had. So that puts them in a different kind of category. The question about the booster and the yearly need comes down to variants. So if we're not going to get this under control worldwide and we're going to have all kinds of new variants, then we will need a boost with a different spike protein that's going to provide different protection against whatever variant comes. So I think that is going to be the bigger driving factor versus our the duration of our immunity. as with most vaccines, we will need some booster. How often and how frequent, I think, will depend more on the variants than on the immune response. And I should tell you, the only vaccines we don't boost on are the live vaccines. So this is a non-live vaccine. We'd expect to have some booster need.
Thanks. That really puts it into perspective with regards to other vaccines that might be a bit more familiar with. I'll turn now to our panelists. Does anyone want to speak about any observations in their practices about long kind of COVID symptoms? Any patients that you're seeing with exhibiting something like that?
Sure. So I have a number of patients with long COVID, and going back to my notes from before we categorized the entity, it's clear there were other patients. Most people, if they get sick, get better after 7 to 10 days. But with COVID, it tends to be less than usual, and it tends to linger. And we do notice that, I don't know, about maybe 10% of patients have persistent symptoms after the expected period of time. And so what's happening is that as more people are getting COVID, we're accumulating patients. So we're seeing more patients that have unresolved symptoms. And some of that is physical. So, persistence in difficulty breathing or difficulty exerting effort, going upstairs or trying to run or something like that. And other aspects are psychological. So somebody had a very traumatic experience, and so they can have anxiety, depression that they might not have had before that, or symptoms that are exacerbated that they previously did have. And so it's a huge problem, especially in younger patients who tend to do well, don't necessarily get as hospitalized, although with the variants it's a different story, but up until now. But they can have persistent symptoms. I have some patients who I've been following for 7 months who are not back to themselves and have not been able to return to work. And so it's scary to have that as a potential outcome, whereas that really wasn't the case with things like the flu and a cold. You eventually got better.
Thank you.
I think a point also needs to be made. We're talking primarily about vaccines here, but we also need to understand that the vaccine prevents us from getting very ill or from having symptoms. It does not prevent us from transmitting the virus. And I have seen and spoken to and heard about people who get the vaccine and they figure they're good to go, and they'll go and visit their parents, their elderly parents, and get nice and close so they can hear. And that's problematic because, as we now know, the protective effects of the vaccine aren't really fully in force until 12 plus days, maybe 14 days. And when we're vaccinated, we can still get the virus and we can still transmit the virus. So I just want to put the message out there that the masking, avoiding breathing the same air is still paramount, whether or not you've been vaccinated.
In terms of the long COVID symptoms, I won't add too much. I think Dr. Artem said it very well. I think the key thing that I've seen is that it's the long COVID symptoms don't affect just older people or people who maybe have a higher tendency to get severe illness. The longer symptoms can be in somebody that's young, healthy, no medical problems, a varsity athlete, whatever the case may be, that those types of people who may feel that they're immune to more severe symptoms are not immune to that or to long COVID. So that's something that can affect kind of any population. And again, speaks to the importance of anyone getting the vaccine and saying, oh, well, if I get it, I'm probably just going to be sick for a few days and I'll be fine. You're still at risk of having those types of complications. And so that's another point that I wanted to make.
Thanks so much. I'm going to throw this one out to everyone. So all of our speakers. It's a great question. If each of you could get one message out to your community, we have people calling in from different parts of Canada, or maybe a message for all of Canada, what would it be relating to the COVID pandemic? Why don't we circle back to Dr. Cora, and then we can go maybe west to east across the coast.
It's a tough week this week because we're hearing more about the variants, the numbers are going up. We're in the middle of a phase 3, of a wave 3. And it sure doesn't feel nice to think that Canada's at the top of the world in terms of new cases. But my message is, don't lose faith and don't lose hope. Humanity has seen worse than this. We're gonna beat it. And it's not hopeless at all because we have really good vaccines, so much better than I dreamt that we would have. And they're so much faster. And some of you were asking in the chat, why doesn't Canada have enough vaccine? I think we will have enough vaccine for everyone. But hang in there, because it will be over. And please get vaccinated and talk about this vaccine to your friends and family, because you can have a great influence on the people who trust you the most.
Thank you. Dr. Markevych, your message?
I think that was a very good one. It's hard to follow. I think that is important. And I think in terms of getting vaccinated, I think getting vaccinated as soon as you have the opportunity would be key. I think there's, people saying, oh, I want to wait until I can get this vaccine, or this vaccine is better. I think the best vaccine that you can get is the one that you can get in your arm right now. And all of the vaccines have been shown to be effective. All of the vaccines have shown to reduce severe illness. And I think that, as mentioned, the faster that we can vaccinate our population, then the sooner we can get COVID under control, the sooner we can see reduction in new variants and new mutations popping up around the world. And so I think the key here is that one isn't necessarily better than the other. They're different from each other. They were tested under different circumstances. They all work. Get one if you can.
Thank you. That's excellent.
I have to admit, I was also perusing the chat questions, and the question came up about, what do you say to the people who want to wait for a particular vaccine? And I totally agree with Drs. Olesia and Dr. Cora. Anywhere people have been vaccinated with any of the vaccine, there has been an improvement. So if you're talking about a percentage or 2 or 3 difference, that's not really going to make a difference for you personally. The speed with which we vaccinate our communities are going to make a big difference. And I know different strategies are being discussed and I believe implemented. For example, ring vaccination, going to areas where there's an outbreak or concentrated cases and get a lot of people in that area vaccinated. I think that's a very positive concept to be doing. And I would just implore, our guests listening tonight, get out as soon as you have the chance and get that shot in your arm. Thanks.
Thanks. And Dr. Luhovy?
Yeah, so I agree with the other panelists. I think in terms of providing, maybe a different message, it would be that if you do have symptoms, whether or not you were vaccinated or not, get tested. So because nothing's 100%, because there is a chance that after a vaccine, either because it's sooner or just later and it's bad luck, it is possible to get COVID, and the symptoms at this point, I think everyone knows what they are, but basically anyone who's got a cough or, just fatigue, loss of smell or taste, just one of those things, or, 2 non-specific symptoms, and in some jurisdictions, 1 non-specific symptoms with the right context should get tested. The advantage of that is then, instead of, guessing whether or not this could be this or trying to, create a story, then
Thank you so much. I think knowledge is key. That's something I think emphasized through today's presentation, through all of our discussion this evening. We're just at the top of the hour, so I'm going to start to close off. Firstly, just thank you for our participants in submitting their questions. We have been taking some notes. There have been more questions than we've been able to get to, but we will try to follow up and communicate some more information following this event. I'd like to thank our speakers from 19toZero, Dr. Cora Constantinescu, a fantastic job delivering a lot of complex information in a really approachable and personable way. It was very informative. Thank you to our panelists as well for your participation and for everyone attending today. Keep in touch with the Ukrainian-Canadian Congress. We invite you to visit our website, www.ucc.ca, where there is an updated COVID-19 resource page. Once again, we'll close here. Thank you to everyone. Please stay safe. Please stay well. Дякую.